This mini lecture is going to cover normocytic anemia, also called anemia of chronic disease. Normocytic anemia is mild or moderate anemia, which is caused by a chronic systemic disease, and it is defined as an anemia associated with normally sized red blood cells. And although the normal ranges vary with age, the MCV is usually around 81 to 99. There are many forms of normocytic anemia that have normally shaped red blood cells as well, although there are some conditions that are recognized by typical abnormal morphological findings of when you do a peripheral blood smear. Most commonly, these are chronic infections or inflammatory processes, such as from the autoimmune diseases. You might see it with lupus, with rheumatoid arthritis, with an anti-inflammatory bowel disease, and also with cancer, liver disease, and kidney failure. And all of these do lead to impaired red blood cell production. Normocytic anemias cover a broad range of diseases and conditions, and they all have their own epidemiology, and they all have their own prevalence rate. Nonetheless, it is possible to estimate that the incidence of a normocytic anemia of chronic disease is recognized that at least half of patients with some type of chronic disease will develop this over the course of their illness. As I said, most patients with anemia are asymptomatic. They come in with very vague complaints of fatigue and weakness. They just don't want to get out of bed in the morning, and they correlate it maybe with they're not getting enough sleep, or they're working too hard, or they're taking care of their children and just running all day long. But they also may have some episodes of dyspnea with exertion, and they really don't correlate all of this together at the same time. These patients, when they present like this, you start doing your normal workup on them and getting your past medical history. Are you having any time of inflammatory issue going on? Have you been seeing an infectious disease specialist? Do you see a rheumatologist for any type of autoimmune disorder? Do you have any kidney cancer, any renal, any other kind of cancer, leukemia or anything? Do you have chronic kidney disease? Have you been diagnosed with that? So these are some of the questions that we need to find out when we're doing the past medical history on these patients. The physical exam, as I said with the other anemias, they most likely no specific physical findings, and the skin may have some pallor to it, but there's usually not many things that you'll find on physical examination. Because normocytic anemia rarely presents with a moderate to severe anemia of less than 30% hematocrit, many of the patients come in and don't have those subjective findings. So you have to really question them a lot closer on why they're feeling fatigued, what they're doing in their life, and that type of thing. For diagnostic testing, their hemoglobin levels are usually around 7 to 11. And their MCV is 81 to 99, and they might have a low reticulocyte count, which would be reflective that there's some ineffective erythropoiesis going on. Typical findings, though, regarding the iron status is that you're going to see low serum iron concentration levels, low or normal transferrin levels, which is elevated if they do have iron deficiency anemia. And they may have some low transferrin saturation levels, and that would be low in iron deficiency anemia, as well as serum ferritin markers, which is that marker of iron storage we talked about before. That could be normal or increased, and your TIBC would be high if they do have iron deficiency anemia. So the initial testing begins with the CBC, and we talked about that also. These anemias have a tendency to kind of be very gradual, or you could see someone come in with a real prolific type of anemia that has a lot of abnormal results showing on the blood test. So when we're looking at management of these patients, it's usually usually there's no treatment that you really need if they're having if it's a mild asymptomatic anemia. But the bottom line is that you need to be looking at controlling the underlying problem. And so correcting the anemia may be that you have to correct some other issues in order to get that anemia to be corrected. A lot of times these patients are being managed by nephrology, they're being managed by oncology, they're being managed by rheumatology, and they may want to give them some purified recombinant erythropoietin because that may be effective if their anemia is from any of those conditions, such as renal failure or cancer or an inflammatory process like rheumatoid arthritis. But follow-up is really going to depend on that underlying disease. If their normocytic anemia is not accompanied by any abnormal reticulocyte count, then you can really do a follow-up on them every 6 months. When you're doing that, you want to make sure you're doing a history and a physical and make sure you're getting a CBC and a retic count. And usually no referral is required for these patients. You can manage them in primary care without any problems. Now, if the peripheral smear that you would do is positive for spherocytes or sickle cells, then they may need to have a hematology evaluation for further workup and management, and see them on a regular basis. If the retic count is low and you discover a low white blood cell and platelet count, then they may be diagnosed with pancytopenia, and you need to refer them to hematology to see if they need to have a bone marrow aspirate or anything else that they may need there. If it's normal or high white blood cells and the platelet count suggests that need for referral, then you need to make sure you do that. They may need to see gastroenterology. They may need to see, as I said, infectious disease, cardiology, nephrology, any of that. The other important thing we need to do is make sure to educate the patient, because this is real important. They need to be instructed to be as active as possible. Make sure that if they get really tired, that they rest. They need to remain vigilant for any signs and symptoms that their hematocrit could really be declining. So telling them, if you notice extreme shortness of breath, your heart seems to be racing, you're getting palpitations, you're getting fatigued a lot, then you need to come in and be evaluated. And then making sure that they know that what the signs and symptoms are, because a lot of them don't, they chalk it up to being anxious, or they chalk it up to being just fatigue from taking care of family.